I'm here with Sam Masket. Sam, you gave a wonderful talk, really an innovative thing I've never heard of, but I'll tell you, in my conversations with you, that's not unusual. Let me get you to flesh this point out, but let me just set up the clinical story. A patient comes in, a lens exchange is justified. Let's forget about even why. The problem is that it's not super recent post-op from the first cataract surgery, and there's phimosis of the capsule, and the capsule's leathery. And Sam, I'm dreading this case because I know that I'm just going to have no control of the capsule once I start making snips. What did you talk about today?
So what I considered was the use of the femtosecond laser to create a secondary anterior capsulotomy. If one were to use scissors to relax the phimotic capsule or a YAG laser preoperatively, either of those situations you'd have an uncontrolled anterior capsule. It might tend to split out as you try to remove the lens that's firmly entrenched in the bag. So I used the femtosecond laser. I've actually adapted both the LensX as well as the AMO laser to make a new anterior capsulotomy, peel that tissue away, and that enables you then to remove the lens without having to deal with the confines of a small anterior capsulotomy. I mean, certainly you still have to deal with the haptics which are embedded in a fibrotic shell, but we have methods for dealing with that as well. But I think the point here is that you can consider use of a femtosecond laser for a new secondary anterior capsulotomy to help you with lens exchange. One of the cautions I would make, though, is that the lens will be scored by the laser, so I would not do this just for the phimotic capsule. I would do it also in those cases where I also want to remove and replace the intraocular lens.
Sam, this is so cool. This is the neatest thing they've heard at this meeting. Let me ask you, the capsulotomy protocols, algorithms built into the computer, the computers driving the femtos are very, very, very good, and we don't get a lot of tags, but we can still get some. What is the result of the capsulotomy like in this circumstance where you have this big, thick, leathery capsule? Do you get a free-floating capsulotomy? And if not, how concerned do I have to be about tags with this sort of situation?
Right. So I adjust the energy level. I raise the standard is usually at 4 microjoules, and I raise it to 10 microjoules to cut through the fibrotic anterior capsule. And in most cases, the cut will be complete. You can use micro scissor to finish the small tags that you may have, but that has not been the problem. But again, I increase the energy level to 10 from 4 microjoules from the default settings.
Now, granted, the size of the capsulotomy will be dependent in part upon the patient's pupil size and all of that sort of stuff. Having said that, in the ideal situation, what is the size of the capsulotomy that you aim for in a case like this?
I'd make the capsulotomy 5 millimeters. This enables me to still have an overlap if that's what I want, or reverse optic capture, whatever I want to do. But 5 seems to work well. And unlike a fresh capsulotomy, which tends to have some centrifugal pull, these will stay exactly the size you make them.
Sam, this is so cool. I'm really happy that you brought this to. I'm really happy that you thought of this. I'm really happy that you brought this to us, and as always, that you've been so very generous with your time with us today.
Well, thank you very much for listening.